Hey everyone, welcome to Taking the Pulse, a healthcare and life sciences video podcast. I am Heather Hoops Matthews here in the studio today with Maynard Nexon healthcare attorney Matthew Roberts. Matthew, it's good to be with you.
Good to see you. Glad you're here.
And we have returning one of my favorite guests. Yes, Dr. Kashyap Patel. He has been on two previous times, so I think this is time number 3. For our audience, as a reminder, if you don't know Dr. Patel, he has just an amazing, experienced medical career with leadership roles on a national level. He founded his own medical practice, Carolina Blood and Cancer Associates. He founded a nonprofit, No One Left Alone. He is doing cutting-edge work, getting national acclaim on long COVID. And that was the last time we talked, Dr. Patel. You were just getting started with that. It's been a little over a year ago. If you would, tell us what you've been up to since then.
Thank you, first of all, for asking me to join this podcast. It's always good to come back to you and Matthews to share what's happening on the field. So since our last conversation, we are now maturing of our understanding on the long COVID and its impact on the society as a whole and where we are heading. Also, our No Left Alone, one of the not-for-profit that looks at the healthcare disparities and how do we address it. So we are maturing there as well. And the last thing is recently I had been approached by Penguin South Asia's SVP. She made a personal visit to Charlotte. She came to my house and insisted that I work on 2 more books after she saw my first book that went very well. So she literally held a gun on my head and saying, Kashyap, you need to have these 2 books ready by the end of the year. So I'm up to those 3 things.
Yes, you're a busy man, very busy man. So let's talk about long COVID, because what you're doing is very interesting, and this is information that we would all need. At least one definition of long COVID is a syndrome characterized by the persistence or development of symptoms attributed to COVID-19 more than 12 weeks after the initial infection. Why don't you talk a little bit about what you've been doing? And you are an early warning signal, frankly, for this issue, because some of your patients and colleagues started to identify things. But let's talk about the basics of what is long COVID, and then we'll get into a little more detail.
And you defined it very well, Matthew, that long COVID is the persistence of symptoms of the COVID way beyond 12 weeks. And then initially, the CDC as well as the National Academy of Sciences had kind of defined the association of long COVID symptoms along with the lab abnormalities, but now they've come even to say that persistence of symptoms 12 weeks beyond the original infection is sufficient to define the person with the long COVID. But it's been worrisome. There are few physicians who regularly send me patients, even they may not have some blood disorder or cancer disorders, with the long COVID symptoms. And I've seen people very young in their early 40s, early 50s, becoming disabled, that they cannot work because of forgetfulness that they get because of joint pains. And I've been noticing some weird things in addition to some, like the neurological manifestation that includes even now inflammation of the liver as well. So I really don't know where we're heading, but there's definitely a warning sign that we should not be turning blind eye to the long COVID symptoms.
So Dr. Patel, if you are a person who has had, which a lot of people have had COVID, what should you be watching for when you're thinking about whether or not a person has long COVID? I mean, before you go to your doctor, is it COVID-like symptoms, or is it new particular symptoms that are emerging? I know we talked about brain fog, some cardiac arrhythmia, and some respiratory issues. But what should the average patient be looking about? Not to panic people, but to educate people what to be looking at.
So that's a very interesting question, Matthew. The acute COVID symptoms are quite different than the long COVID. It's because of the mechanism. So acute COVID actually is something called the inflammatory response of the entire body to fight back the infection. And then some people get high fever, loss of smell, shortness of breath, respiratory failure, all of that. When you look into the long COVID symptoms, they are mainly conglomeration of the tissue impaction with autoimmunity. So it's our body's response in form of lung inflammation. So if it impacts the nerve in certain people, then they start getting tingling, numbness, or unexplained kind of pains. Some patients get forgetful, like what you said, the brain fog. That's probably is primarily CNS involvement. And some patients may get some cardiac arrhythmias. And now I've been seeing patients with unexplained swelling in the liver in terms of hepatitis, chronic hepatitis, which is not linked to any viruses, and a joint pains, of course. And the worst thing is vague feeling of illness without knowing what it is. Like you just don't feel like doing anything when you wake up in the morning. Day-to-day operational forgetfulness, you forget, oh my God, I had to take a key, and then you forget, did I take the key with me or not? So these are some very common symptoms that I've been noticing in patients. I came across, I think, two very relatively healthy people about before COVID. One was a pharmacist, the other one was working in the Chester in some government entity. They both cannot function. They said, we are not capable of continuing our day-to-day work.
Dr. Patel, what do you do if you think you have something like this? Like, where do you go? Not everybody can go to your practice.
So I think we need to bring awareness. The thing that I'm concerned about is we become somewhat complacent. I think because when we had the acute global public health emergency declared with COVID, there was a panic and lots of things kind of were done in a hurried way. And now because of that stigma of like rapid response without kind of, full consensus, it seems that, the society is turning blind eye. But last figure I heard was that 7% Americans, that's 1 in 14 Americans, have long COVID symptoms. And that's not a small number of people. I read another article recently saying that before we realize there will be huge surge in disability claims from employers as well as the Social Security office. So we probably may be just on the edge of something that may be coming. It may not be kind of deathly in terms of it may not be fatal, but it may cripple the functioning ability of large number of Americans.
What about researchers? Where do we stand with researchers looking into this right now? And how are they pulling together findings?
So some of the researchers who have a dedication to rise above and beyond any kind of, popularity images, they're continuing. One of my colleagues, Afshin Behesti, has been working with me and is planning to apply for large amount of funding from NIH to study the long COVID and chronic cancer connections. We applied, and I think we've technically been approved by the state DHEC to study some long COVID from the state government earmark funding. We haven't received a confirmation as yet, but we are looking forward to that. There are some isolated kind of foci that are looking for this, but it's not as big as what we are looking at the population health impact that will be coming our way.
So Dr. Patel, because this is an emerging issue, are physicians, your average internal medicine, family practice physicians, some specialists who may get these patients, are they prepared and educated on some of these things so they can piece together these different symptoms and they may have the ability to diagnose it? And if they are able to do that, what's the treatment?
So unfortunately, my frustration is that only 1 in 20 physicians is really meticulously kind of familiar with the long COVID symptoms. And that's once again, we got so back into real rhythm of life that I think the whole kind of episode of long inflammatory response was forgotten. But if somebody, when they get diagnosed with long COVID, because it's primarily an inflammatory mechanism, there are some medicines, for example, low dose prednisone steroid that may help. Some patients actually have been placing them on what they call low dose naltrexone, which is, there have been some studies that have shown that low dose naltrexone may help some symptoms of the long COVID. And I've been talking to some of my pharma colleagues who are at a higher position to see if they can start looking into some sort of clinical trials on the already approved anti-inflammatory drugs. There are drugs available in the market that are good anti-inflammatory, but because we were turning the eye away from the big issue because of whatever is it, stigma or whatever, there are not many trials going on right now.
Yeah. How about the insurance companies and the health plans? Are they agreeing to cover some of these treatment costs for COVID, long COVID?
They are, and fortunately, these are generic drugs. So, like for example, I spoke with our local pharmacist and he said, "Can you compound this 3 milligrams per day dose?" And they charge probably $20, $30 for a month supply. So the drugs are not expensive. I would say there are 3 or 4 drugs that are being tried in different arena. They don't cost more than like $20, $30, $40 a month for a month supply for as an anti-inflammatory. Now, if you start going into infusible products, that could be a whole lot different story. But as of right now, the insurances are covering the drugs and they're covering tests as well.
But there's not a test that would identify. So if I or anybody went in to test to see if they have it, there's not really a definitive test.
There are actually, yeah. So International COVID Research Team has recommended about, I think, 6 different tests in the blood. The one is called IL-1, interleukin 6, FDP-D dimers, C-reactive protein. So there are about conglomeration of 6 tests and also CT scan of the chest. And they also have shown that what percentage of people with the long COVID, this test would be positive.
Okay. All right.
I don't want to change subject because this is such an interesting subject, but you also do so much good work through your nonprofit, No One Left Alone. If you could talk a little bit more about the work with helping to reduce healthcare disparities, where you stand, and what the future looks like in your efforts.
Thank you for kind of bringing back that topic because that's very near and dear to my heart. And we started learning about disparity when the American Association of Cancer Research published a report in 2020 on disparity, showing that 34% of cancer deaths can be prevented in America if we address disparities. Plus, we would be spending $100 billion less annually in the healthcare costs for cancer patients if we do disparities. So we started this foundation, and these disparities are actually simple solution: transportation help, food insecurity, childcare support, utility help. Imagine on 95 or 900 degree heat, if a patient goes home after chemotherapy, they may already be a little bit confused with the multiple drugs. If they are in a house that does not have utility, they may be subject to heat exhaustion because they may not realize physiologically that they have to find a way to help themselves. And if they don't have a way to have air conditioner on, that's an issue. So barriers to access to care above and beyond medical causes, which is social determinants of health. And we understood the impact. And I was surprised to find in the first week, we found 3 patients who are living in a car. And I didn't know about this until we started studying this. And then as we collect data, by now about 4,000 patients, of that, about a third of them have some sort of either issue with the cell phone connection, food insecurity, housing issue, utilities. And my team is making effort to connect them to the resources. So it's going on very well. And we've now prepared what we call a playbook and almost like a manual or standard of operation. So anybody who wants to replicate that, we would make it accessible to them as well. And I've been in conversation with one of the big health systems in Miami, and their chief medical officer wants to come here and see if they can work with us and replicate our NOLA model to take it to the healthcare system.
Right. Well, it's a great program, and obviously you have helped a lot of people locally, but you're capable of helping a lot of people beyond just the Rock Hill area. So we continue to support that. Let me ask you a question about your practice, and you remain one of the few independent oncology practices in the Carolinas, and you have a very good relationship with most health plans because you, more so than a lot, have been very focused on what are they focusing on cost, quality issues, and helping new initiatives be developed between payers and your practice. You did all of these things before value-based care became a thing that people talked about. Can you talk a little bit about your vision of how you look at working with health plans and payers, and then what you see going forward as the future of value-based care for physicians?
Thank you. Again, this is very near and dear to my heart. And we started working with our commercial payers as well as CMS on the value-based care. We forget in the calculation of value-based care is that patients should be at the center, not the cost and not artificially defined parameters of checking the boxes. So we decided to build up an ecosystem that, patient when they come, we want to see them as a whole patient. So patient has their own family members, children, and in order for me to serve that patient best and bring the best value to the society, I need to make sure that I reduce the risk of preventable hospitalization. So when I discussed that with the Blue Cross Blue Shield's Chief Medical Officer, both Laura Long and Sean Stinson, they understood very well. And we defined a model based on the number one achievable target to reduce cost and improve the outcomes is prevention of preventable emergency room visits, which by default ends up in the hospitalization. So imagine 40-year-old breast cancer patient who's got 3 kids at home. She works at Walmart. If I can reduce her risk of going to hospital by seeing her at 6 p.m. on Thursday evening, I can give her family back 5 days. I can reduce her children from missing their mom, and I can reduce her debts because she can continue to work at Walmart. So the simple solutions that we have are frequently ignored because we are focused only on the dollar, and artificial defined checkboxes. So we said, no, let's build an ecosystem to work with the payer providers and even the pharma companies, because if we work together as like trifecta, then lots of problems are achievable. And our experiment showed that we brought down the cost by about 30% for the CMS beneficiaries from the CMS figures. So if we could do that, anybody else can do that if they focus on keeping patient-centered cancer care by keeping patient at the center, not the dollars.
And you've been a leader of that, and I hope you continue to do that. And I hope you are an inspiration to other physicians who will take that mantle up and keep it up, because it's an issue that is a common ground for payers and providers.
Mm-hmm. Exactly.
But Matthew, you heard what he said. Like, if I see the patient at 6 o'clock at night, I save five days for the family. And Dr. Patel, I'm not sure everybody's willing to sacrifice like you are.
So I think coming back to this is very important point you raised, Heather, is that if payer realizes that by providing little extra incentive to physician to stay beyond 5 p.m. to take care of the patient, put some modified 25 and say, okay, you saw a patient after hours, we'll pay $200 extra because it costed you and your nurse extra time. These are the values that our society forgets. And I would tell you that, being a small practice, going back to Matthew's point, in 23 years, with our collaboration with the payer and pharma and other social entities, not a single patient has been turned away. Not a single patient actually is in debts from at least medical debts. And in 23 years, we've not had a single malpractice lawsuit.
Well, I want to tap into that, because a lot of practices don't, quote, turn away a patient, but they make it difficult to get access if if the practice is full. So it's not turning away someone showing up sick necessarily. But Dr. Patel's practice has gone an extra step. They make it easy to get in. And so his waiting room will be full of people who didn't have an appointment from time to time. So that brings me to the final question, Dr. Patel. We've talked about this, one of the big issues in medicine, everybody means to do well. So hospitals, physicians, payers, I'm giving that. But there is this disconnect between communication between physicians to physicians, physicians to hospitals, and it boils down to the patient. You've always had a very good ability to communicate directly to the patient about what's happening, particularly when you're dealing with cancer and it's a life-threatening disease. What's your thought on that, your vision on how to maintain and improve communication across the board and do a little bit of what you do in your practice, but across the healthcare delivery system?
I think, we have demonstration project that we've shown. So the entire problem begins with the working in silos. So for me, it's only patient's 2 centimeter mass in the breast or a lung. That should not be the case, because that patient may have diabetes, that patient may have COPD. And if I can collaborate their care by communicating with my colleagues, lung doctors, saying that, yes, I'm looking after the cancer, but this patient's chemotherapy may exacerbate his COPD. Would you be willing to see that patient as soon as they need so that they don't have to go to hospital? It all comes back to communicate, collaborate, and cooperate. So my cell phone number is virtually with most of my colleagues in our area. And usually they send me patient text and said, Kashyap, will you see this patient tomorrow? And I said, yeah, because if I had to stay extra 20 minutes, I'm fine with that. So, and we built up that environment of collaboration within our community. And that's the reason why we are able to provide optimal care without any barriers.
You should add another book to your busy schedule on that issue, because I think that's a pressing issue that the patients across the country would benefit from if more people adopted that attitude.
Absolutely, yes.
Dr. Kashyap Patel, you are a blessing to our region and the nation. Thank you so much for your good work, for joining us again for the third time. And I know that we're going to ask you again, so I hope you will join us again in the future, probably next year.
Thank you very much, and thank you for giving me a chance to come and share my views. Thank you very much.
Thank you, sir.
Take care.
For all of you who joined us today, we hope you enjoyed this episode of Taking the Pulse, learning a little bit more about long COVID, about a nonprofit focused on health disparities with cancer, and about just a really compassionate way to make the healthcare system work well. We look forward to seeing you next time right here on Taking the Pulse, a healthcare and life sciences video podcast.